All right, everybody. Moving on with chapter 14, because the last one we put online was chapter 12, assessment, and then we did vital signs on day one, actually. So we're moving on to 14, and I will put vital signs up online as well, but I wanted to stay on track with what we're doing right now. So now we're in the secondary assessment, and we're going to break that down a little bit. Mainly, it's just you can read through those. Body system examination, secondary assessment of the medical patient, secondary assessment of the trauma patient, detailed physical exam, reassessment, critical thinking, and decision making. So we talked about primary assessment, with chapter 12. Excuse me. So today we're diving into now. We did the scene size up, right? You determined what the condition of the scene is, whether it's safe, not safe, how far away to park. Basically, it's a chaotic situation when you pull onto a scene. So you're constantly assessing that, and then when you get to the patient, you're really just doing a quick assessment to find out why you're there. Why were you called? Was it a sick patient? Any life threats immediately that you got to intervene with? Because you're not going to go into a secondary assessment if the patient doesn't have a patent airway and you got to get an airway moving. That's going to be your priority. Then after you get that airway moving, then you'll move on with your assessment. So keep those in mind. So components of the secondary assessment is the physical examination, head to toe assessment. Now, a medical call will be different than a trauma call. A trauma call, we do a head to toe quick assessment. Feeling from, everything from the top of the skull down the face, the JVD, the throat, trachea, chest, abdomen, left arm, right arm, pelvis, right leg, left leg, all the way down to the feet. I mean, we're constantly do a quick head to toe on a trauma patient. Physical examination on a sick patient is a little bit different on how we do that. And so a patient history is also important. History of the present illness. And then past medical history is going to be important as well. If you have a patient who had a seizure, is a seizure a common thing? In the history, you're going to find out is there a past medical history of a seizure? Do they have epilepsy? Did they have a head trauma a month ago? How often have they been feeling? Sometimes people have their first seizure, but they've been feeling ors for a year. Where they just have days where their brain don't seem to be functioning properly. They have migraines. Past medical history will help guide us in a direction of how we want to treat that patient. And then history of the present illness. What was the patient doing up to this point? Was the patient working hard in the field, working with cattle, and then all of a sudden start wheezing and have difficulty breathing? Then you got a potential environmental asthma attack. So history of the present illness, and then vital signs. Again, those vital signs are crucial. Blood pressure, what's it doing? Pulse rate, what's it doing? Respiratory rate, what's it doing? The sign, something that you can see. So we always talk about signs and symptoms in EMS. So signs are the things that we can see. We can see the cyanotic around the lips, so we know there's a difficult pulse oxygen. There's not good perfusion in the body at that point. Signs, one people's reactive, their people's not. Signs of the trauma, JVD, the jugular vein distension. So we know that there's a issue with that. So signs are things that we can see. Symptoms is something the patient can tell us. Well, I've been having lower abdominal pain in my left side for 3 weeks, and now it's just the point where I can't handle it anymore. So we called because I need to go get checked out. Something the patient tells you. Well, I had someone explain to me before. I felt like my brain fell asleep. That's a symptom. It's a strange description, but yet a good one because it tells you quite a bit going on. So lightheadedness. Now, the reassessment is a continual process. So you're going to do that from the moment that you hit the scene to the moment that you drop off the patient to the hospital. Rule of thumb for our department is I want you guys to have 3 vital signs on every patient, regardless of how close to the hospital you are. Now, the point of that is that you get a vital sign you get a vital 1 or 2 vital signs on scene. Then you get one in the back of the ambulance. So if you get 2 on scene, 1 back in the ambulance, that's 3. Just work it out. But the point is that you want to find trends. Is blood pressure dropping and going in a good range? Is it raising and going in the bad range? You want to have trends to show the hospital as you do these things. So So we're going to take vital signs um, as often as we can: pulse, respirations, blood pressure, pulse ox. Measuring oxygen saturation of blood, which is the pulse ox, and you will assess the skin color, temperature, and condition, and pupils of the eyes. Are they pearl or not pearl? Vital signs we were covered, in the previous chapter, so you kind of just want to revisit that. The vital signs is the key to BLS, really. That's key to ALS too, but they can do more interventions than we can. So as you check these things, you're going to be able to find things to report to the hospital, things for you to intervene with, and also give the hospital direction. History taking techniques. Um, it sometimes can be a tricky situation to be able to get those um, the history taken. So it's either obtained by the patient, or if you're unable to talk to the patient, you talk to the father, the mother, someone that's a bystander nearby. But this main thing is that it's an important thing. So ask open-ended questions. You do not want to put words in their mouth to have them give you symptoms that they're not really having, and it's amazing how often that can happen. So I just ask open-ended questions. But one of the things like I'll ask the bystander or the patient, is what were the events leading up to this moment that you felt like you had to call us? How long has this been going on? How long has the patient been having back pain? How long, if they had a seizure, how long did that seizure last? Because seizures have the pre-phase, the postictal phase, and then the status phase. Status phase is the seizure, postictal is after. So I want to know how long were they in seizure status? 2 minutes, 5 minutes. How many times were they in status? One time or two times? Because two times more critical than one. So we want to ask open-ended questions as you're talking to the family, and your book will probably go in more descriptions than I'm giving you. I'm just giving you from my experience as well. But these will be in the test. So can you tell me about your headache? It's in your book. Now that's a strange question. Can you tell me about your headache? But yet, when you ask an open-ended question like that, because if you go to someone and say, "Hey, is your headache sharp?" Well, yeah, it's going to feel sharp because you just put sharp in their brain, and they're going, "Yeah, that's a good description." Tell me about your headache. Well, they're going to describe it according to what they're thinking. It's dull, numb, my brain's asleep. Like that was an open-ended question I asked, so they gave me that one. I didn't go up to them and said, "Hey, is your brain asleep?" They're not, what I mean. So don't put words in their mouth, but ask open-ended questions. Um, so it's in your book. A lot of these, like, does the patient have any existing medical problems? As you're going through it, does the patient have any existing medical problems? Does the patient take any medications? All those will be important. A lot of times you'll get a list of the medications to take to the hospital. Does the patient have any allergies to medicine or the environment? And when did the patient last eat and take by mouth? So um, those are going to be important questions. So read this section really good in your book. But a good description they put in here too is a closed-ended question is a question requiring only a yes or no answer, which is going to be tough to do. A question requiring more than just a yes or no answer is an open-ended question. So that's a good description on how they break that down a little bit. But I also stand by the fact that we don't want to put words in their mouth. We want to be able to ask them questions that leaves it open-ended, so they give us a detail. Do you have a headache? Yep. That ain't gonna tell you much. Tell me about your headache. Now they're gonna have something to say to you. Um, and then also using the mnemonics that you see on in your book too is sample and OPQRST. These are important tests. You're gonna have these from now on through the class, through the registry. You're gonna have them. These are tough. So sample is signs and symptoms. A is allergies. M is medications. P is pertinent past medical history. L is last oral intake. And then E is events, so events leading up to. So when you go and do an assessment, you want to go through situations like that. You use sample. So what's wrong? So when you go through your assessment, so like we did the head to toe, for example, with a car accident, but now you're going. This is more of a situation that you have something to help you not forget to take a step. So like here are some examples. So sample of a sign and symptom is what's wrong. This is a reminder to get the history of the present illness. So, what is wrong? Why did you call us today? Allergies. Are you allergic to medications or foods? Because obviously, we're not going to want to give meds they're allergic to. And do you have a medical identification tag describing your allergies? But medications. What medications are you currently taking? Because that's important to lead up to the fact if they're epileptic, did you take your medicine today? No. Oh, well, that's probably part of the reason they're having a seizure, right? Um, if they're diabetic, did you take your insulin today? Um, so, are you on birth control pills for females? Do you have a medical identification tag naming the medications on it? So, do you take any herbal supplements or vitamins or minerals? So, when you're going through your assessment, these are questions you're going to ask for medical history. Pertinent past histories. Have you been having any medical problems? Have you been feeling ill? Have you recently had any surgery or injuries? Have you been seeing a doctor? What is your doctor's name? That's good for us to know because since we're such a small community, that absolutely helps. There's times I'll call Dr. P or Dr. Miles while I'm still on scene sometimes if I feel like it will help the situation. But also past medical problems. Have you been having issues for a while? I had a heart attack not too long ago with somebody, a heart attack call, and for 3 years, or they were talking about, well, potentially they said 10 years, but three critical, lightheaded all the time, couldn't stand up very long, their legs were swelling. I mean, you're talking 3 years of problems. So now they're also having a heart attack. That's going to get you on the ball moving, right? So past medical history is important. But another example, is someone that's had a seizure, if it's first time seizure, what was going on before? Have you been feeling, have you been having headaches in the last few days or the last little while? Have you been lightheaded often? Have you blacked out before? Have you passed out before? Asking those pertinent past history. Last oral intake, when did you last eat or drink? What did you eat or drink? It's kind of funny because this is the most common question that BLS EMTs will ask. It's funny because I had a paramedic tell me that they get EMTs in the back of the ambulance. All they can think about is, when did you eat anything? What did you eat last? It's just like that's the most important thing. And it's important, but not the most important. But what did you eat or drink? Um, and then events leading to the injury or illness. So, what events led up to today's problem? The patient passed out getting in the car. The patient, the funny thing is when you have car accidents, sometimes we jump to instantly thinking the mechanism of injury is the accident. But I have seen accidents caused by a diabetic coma or epilepsy or situations like that. So get the events leading up and don't disregard anything. An example of BLS, I believe BLS saves lives. ALS is awesome, but sometimes they get too big for their britches. I had a paramedic one time that could not figure out what's going on with this patient. Could not figure it out. He's in a coma, couldn't wake him up, and he's crashing hard. He's doing everything he knows how to do. 12 leads, giving drugs, giving epinephrine, all this kind of stuff. Guy's not waking up. And finally, checked the blood sugar as a BLS, and he was in the 15. So obviously he's in a diabetic coma. Give him some glucose, boom, he woke right up. Paramedic was so apologetic for not thinking of that. What we got to remember is events leading up to may not always be the mechanism of injury. Mechanism of injury that we see is the most biggest, head-on collision mechanism of injury. Wow, we got the steering wheel in the chest, we got the head in the windshield, we got all these things going on, but we also got to remember what led up to it. It may not have been as easy as running a stop sign. So that's sample, and that is going to be in every single test. I mean, you guys are going to hit that hard over and over again. So take a real big look at that in your book. It says experienced providers learn to ask questions based on the patient's presentation and use the sample mnemonic to make sure they haven't missed anything when they're through. And so when you're going to find your own technique for test purposes, for registry, sample, get it in your brain, memorize it. But when you're in the field, you're going to adapt that to fit you the best. You're going to figure out how you're going to get through these questions. But I want you guys to get it in your brain, because then when you are dropping a patient off the hospital, go through that sample real quick, make sure you didn't forget anything. Then the OPQRST is onset, provocation, quality, region, relief, severity, time. So onset is what were you doing when the pain began? Again, similar sample. Provocation is, does anything seem to trigger the pain? Does anything make it feel better? When you sit up, does the pain in your back lessen? When you're laying down, can you breathe easier sitting up or laying down? What gives us relief and what makes it worse? A lot of times with congestive heart failure, or when there's a fluid in the chest, when they lay down, they can't breathe. They're drowning. So when they sit up, oh, I got relief. Provocation. Quality. Can you describe it for me? Um, is it, that's where they're going to talk. Is it dull? Is it sharp? Is it tingling? Is it, describe the pain or describe the discomfort. Region relief. Where is the pain? Will you please point towards it? Does it seem to shoot or spread anywhere? Um, if they got a neck pain, a disc in their neck, it's going to trigger down the arm. If they're having a heart attack, it's going to potentially, for the man, it's going to go down the arm and up the jaw. Um, for females, their symptoms are different for heart attacks. But we have to look at these things. The severity, how bad is the pain? I always ask the same question over and over again. 0 being the nothing at all, and 10 being the worst pain you ever felt in your life. Where would you rate this pain at? 7. Okay, so now I know I got where they're kind of laying at. And then I also ask, after treating them, when I'm getting ready to be at the hospital, I ask them the same question again. So I want to know, did I help? Was there relief before we got to the hospital, or did we actually make it worse? When you spinal someone, um, you want to reassess that pain level because maybe you hurt them when you moved them, or maybe you pinched a disc or a nerve, or they lost feeling in their legs, but they had feeling before you touched them. Again, reassessing the severity of their pain. So onset, provocation, quality, region, relief, and then severity and time. Time is when did the pain start, and has it changed at all since it started? Like I kind of said before, but consider the patient's complaint had a sudden gradual onset. For example, pneumonia is a gradual onset, while asthma is instant. I know I've never been diagnosed, but I use an inhaler. But I know when I'm at the gym sometimes, I'm working out, man, it hits quick. I can't breathe. I'm lightheaded. I'm on the ground. I'm grasping for air. So now I carry an inhaler with me. But that's quick. Where pneumonia, which I've never had, but I've seen people have it, it takes time to get to the point where they're like, man, I need help. Um, so remember to ask open-ended questions, even with this mnemonic, and allow the patient to answer in his own words and listen to what they're saying. In some ways, you're going to feel like a therapist sometimes. They're having the worst moment they've had potentially in their life, and they just want to talk about it too. They're looking at you as you're the man with the badge, and that badge gives comfort. I know it sounds silly, but I believe in being branded because when I go in people's houses or in a car, and they can tell that I have professionalism to me, that's also a comfort to them because they know I'm there to help them, but I want to listen to them because they're going to share things with me that they just got to talk about, and because they're desperate. So make sure to listen. Now, let's get to the physical examination techniques. So, observe. Observation is looking at the patient for an overall sense of his condition, looking at the color, looking at everything from their lips to their pupils. So it may be a very simple technique, but the results are very important. You may use observation. Excuse me. Sorry, I had a I've actually been doing pretty good today, but now I'm just full of congestion. It's allergy season for me. So, so we want to be observing. Look at the chest for expansion. Listen to the lung sounds, equal air movement, abnormal sounds. That's the wheezing. We went through that in the respiratory chapter. Wheezing, crowing, all different kinds of sounds. Palpate for tenderness caused by broken ribs, other injuries. The technique you choose will depend on your patient's complaint and presentation. So your technique's going to change all the time. But when you depend on the condition of the patient. So when you go up to a patient who's having difficulty breathing, he's tripoding when you get in the house. You observe him. You can tell he's really retracting. He's really desperate for air. First thing, obviously, you're going to make sure the airway's patent and get him on some oxygen. Then you're going to listen to lung sounds. You're going to oscillate. You're going to listen with a stethoscope, all 4 lobes. You look at the chest rise. Is the chest rise equal or not equal? Because he's in the chair's tripod and he can't talk to you because he can't breathe, but you don't know why he can't breathe. Is he sick or did he fall down the stairs? If he fell down the stairs, he could have punctured a rib or broke a rib and punctured a lung, so he won't have equal chest rise. But you know, you want to look, chest rise is equal. He's got good breath sounds. They're clear, you know, or he's got some wheezing. Well, that's going to determine how you treat. So you got him on oxygen right now. Watch that pulse ox. Hopefully he gets better. If you put him on that patient right there, I'd start with a non-rebreather, 15 liters. If he doesn't get better, but he's wheezing, I know now, okay, I'm going to give him an albuterol treatment. You know, give him some nebs on the way to the hospital. Potentially on scene, give him some nebs and just make sure he clears up a little bit before you start moving him and making it worse. So just observe those things. You know, check out everything you can check out. It's a simple thing, but and then, like I already said, oscillate. Oscillation is a listening for signs of abnormal conditions. In most cases, oscillation is done with a stethoscope, although some sounds, wheezing, can sometimes be heard without a stethoscope. That's when you're in the room and you can just hear them. Palpate. Some situations and conditions will require palpation. This involves feeling in an area for deformity, other abnormal findings. You will palpate. So when there's a car accident, you're palpating everything, you know, but um, that's where you go from head to toe and you're just feeling everything, find some deformities, some things that are broken, some things that aren't broken. Maybe they have abdominal pain. When you push on it, it hurts worse. When you let go, it gets, you know, with appendicitis, you can push in the lower abdomen and it actually relieves the pain. And then when you let go, it hurts, I mean, worse. So you'll be able to tell that right away. So palpate. And I'm going to tell you this much, is we are blessed as an EMS department because we have monitors in every ambulance. That's not normal for BLS. But my thing for you guys is make sure to still touch the patient. Use your hands because someday that equipment may not be there. So examinations, respiratory system, the most important determination when assessing the respiratory system is whether the patient is breathing adequately. Kind of covered that just a second ago. We want to make sure these people are, you know, good breath sounds, they're clear, um, equal on both sides. Obtain a history of existing respiratory conditions and medications taken for each. You know, if they're having difficulty breathing, are they on nebs? Have they been prescribed albuterol? Are they taking it at home? Are they taking it today? Are they asthmatic? Do they have an inhaler? Do they have COPD? You know, obtain that history of existing respiratory. Determine if medications have been taken as prescribed and determine if signs and symptoms of this episode match previous episodes. So, again, you get that past medical history and then leading up to today, that very moment. So, does your signs and symptoms fit what they've had in the past, or is this different? So, if it's different, that means there's something else that's aggravated or changed or it's gotten critical. Who knows what the case may be, but you treat accordingly. If it's the same as before, you know, if they didn't take their nebs that day and they're prescribed, I'll watch them take them to see, make sure, and then monitor them again. Does that give 5 minutes? Did it clear up? Reassess. But if point is, if it's different than their previous signs and symptoms, that helps us with that as well, determine how we're going to move forward. Mental status. Are they awake, alert, and oriented? ×4, or are they not? Can they tell you where they are? Can you tell them? Can they tell you who the president is? Can they tell you, you know, what day of the week, where they're at, what their name is? You know, check that mental status. Because if they're in respiratory distress and their pulse ox is in the 70s, let's say, they're going to be gone mentally. And then you can reassess as you give them oxygen. Did things get better? Did they come back around? Level of respiratory distress. Chest wall motion, equal or not equal. Oscillate the lung sounds. Listen to all 4 lobes. Are they all 4 clear or not clear? Do you have clear sounds in the top lobes but the bottom lobes are absent? You know, just listen to those things. Use pulse ox. Big time. And like I said, the main range that we like for test purposes, I think it said it was 95. Anything below is bad. I'm always around 90, 94 is good. Observe edema. Do they have fluid retention going on? Do you hear fluid in their lungs? Are the legs swollen? Fever? Um, and then the cardiovascular system, heart, is it beating? That's very important. Is it beating at the proper beats per minute for that age bracket? Blood vessels, blood pressure will tell you, are those blood vessels open or is there too much pressure trying to push through? Cardiac patients and patients in shock or with vascular problems. You're going to have this. Pretty soon we got I think next week or Wednesday we got a cardiac emergency chapter coming up, and that will help add to more of these things. But cardiac patients, are they in shock, vascular problems? Um, so existing cardiac conditions and medications, you get that history. Have you had a heart attack in the past? Are you taking medications for your heart problems? Are you on nitro? All these questions you want to get and you want to ask. And then signs and symptoms of the episode. Does it fit the past? Description of chest pain using the OPQRST. So the onset, the pain. Go through the questionnaire with them. Um, is your pain level from 0 to 10? When you sit up, is it worse or is it better? Determine specific characteristics of the pain. Does it go down the arms? Is it going up the chest? Is it in the middle of the heart? Is it where the diaphragm is? A lot of heart attack. I'm telling you, I've seen so many guys that think they're having a heart attack and all they got is GERD. So make sure to get those descriptions too. And the best way to describe it is say, can you describe the pressure? If they haven't felt chest pressure, can you describe the pressure? And they'll tell you, it feels like someone's sitting on my chest, or it feels like there's a vice around my chest. Um, all those are important things. So the physical examination, look for signs, condition that may be severe. Um, like I said, I've seen heart attack patients and I've seen people thinking they're having a heart attack. You will eventually get that gut instinct, sick or not sick. But look for signs and conditions that may be severe. Obtain a pulse. Is it tachy? Is it bradycardic? Or is it right in range? Obtain that blood pressure. Again, is he hypotensive or hypertensive? Um, and then no pulse pressure. Note the pulse pressure. Write it down, monitor it. Look for jugular vein distension. That's the JVD I was talking about. You'll see those with car accidents and some cardiac problems. Palpate the chest. Don't be afraid to touch them. Especially, I know it's kind of, sometimes these guys are pretty darn sweaty, diaphoretic, and you got to touch them, and that's okay. Touch them and do your assessment. Um, Palpate the chest, make sure it's okay. Observe posture and breathing. Are they struggling to breathe? Watch. Are they tripoding? Are they laying flat on their back? Where are they most comfortable, on their side? I had a guy with a lot of edema in his chest cavity and the abdominal area, and the only way he could find any remote comfort was to lay on his side. So watch the posture. And in your book, there's some good pictures, of that when you're checking them out. So even the JVD, it's really cool. Is in your figure 14.9, you'll see that JVD right there. That's what that looks like. So now the nervous system, mental status. You know, definitely want to get that when you have a call. And there's a lot of different reasons for nervous system calls, but mental status and signs of dysfunction in the body. So that's where you're going to do your assessment for stroke and really check that out. I remember going on a call not too long ago out of town, and right off the bat, guy got in the ambulance with us, um, failed the Cincinnati stroke method, which we're going to teach you. Right off the bat, I radioed the hospital, said this is a stroke alert, let's get air life moving. When we scanned him at the hospital, and he had to go, once he got to Denver, he had to go to brain surgery. He had a horrible brain bleed in the back, and really minutes. You have 4 hours. There's a 4-hour window for stroke patients, and where we live, we're pushing that limit, even flying them out instantly. So you're going to have to make those calls. Um, but determine patient's mental status, determine patient's normal state of mental functioning. So also with these people, when you want a bystander to tell you, is this normal for him or not normal for him? Some people are just strange. Some people have had strokes in the past and they're not thinking clearly now. So you want to get that baseline for their normality and then base off that. But a tame history of neurologic conditions and no patient's speech. Is it slurred, not slurred? Some of these guys will try to say something to you and they're thinking it, but it comes out different words and at random, like purple bunny, drink my coffee, strange stuff, but yet it's real. They're thinking, one thing and trying to say it to you like, hey, can you take me to the ambulance? but yet they're coming out saying, chocolate cake fell on the floor, random weird stuff. Um, to determine their mental status and then what's normal for them in their speech. So a stroke scale is what we want to do. So perform a stroke scale. We usually use the Cincinnati one, and it's in your book here. So I'm trying to find the Cincinnati one to describe to you. But you can see the pictures down there of the guy doing it. So basically, um, have them follow your fingers with their eyes. Don't move their head. Check their pupils, equal reactive. Um, have them smile, look at their teeth, and determine is there a is one of their is there fate is one of their, I'm trying to figure out, um, left-sided paralysis, I guess is the best way to say it right now. It's in your book, but get them smiling, see if it's equal. Close their eyes, hold their hands up, and then you just watch, see when their eyes close. If there's a stroke going on, one side will collapse where the other side won't. So this is a stroke you can find out pretty quick. Um, check sensation and movement. You should check each extremity for equal or absent findings may indicate spinal injury. So what we do is we want them to squeeze my fingers with both hands, push it, grab their feet, push against my hands. Is one side weaker than the other, or are they both equal? Gentle palpate the spine for tenderness or deformity. That's a sign of something broken. Check extremity strength, like I just said. Hand grips, pushing at your feet. Check the patient's pupils for equal to be equal. Those will tell you a lot. Strokes and neck injuries can mimic each other pretty good. So want to just make sure to read this chapter thoroughly. Go through it. We can't go through everything. I've already been talking for 30 minutes, and we're not even a quarter of the way done with this chapter. But check patient's pupils for equality and reactivity, extremity strength, and gentle palpate the spine. Now, the endocrine system is a whole different beast. Most common endocrine emergency is the diabetic patient. So, obtain a history of endocrine conditions, diabetes mellitus or thyroid disease, very common around here. My wife and my daughter both have thyroid issues. So I'm going to tell you this much: is this you're not going to learn a lot as an EMT, but I've seen so many different diseases fall into the endocrine system. And they're always learning something new now about the endocrine system. There's always new things coming out. So, but diabetes and thyroid disease, current medications, and whether being taken properly, both of them, both these, if they're diabetics, they're going to have their own medication, um, insulin that they're doing every day, and same for thyroid. They got medications they got to take every day. If they're not taking it regularly, they're going to have problems. Whether a patient has eaten or exerted energy at an unusual level, both of those diseases there, if they overexert themselves, can cause a negative effect on their body as well. It's very hard for these people to sometimes stay healthy by exercise because it causes issues. Whether a patient is sick, um, have they been sick for a long period of time? Are they sick? Because obviously if they get pneumonia, it's going to affect their diabetes. So whether a patient has taken blood glucose or uses insulin pump, find out what their medication is that they take. We got one here in town that's on a pump. Get called there quite often, but and then also if they have low blood sugar on a regular basis, sometimes my grandma took blood glucose tablets. Um, so find out those kind of issues as well. This again, you get that history, guys. I mean, we're being kind of repetitive about different parts of the body, but yet you get that history, and then you find out is the symptoms they're having now, does it match with their history, or is something different going on? Evaluate patient's mental status. Again, everything's going to revolve around that. Observe the patient's skin color, pink, warm, and dry, cool, clammy, and diaphoretic. Which one is it? To obtain a blood glucose level right off the bat. I mean, if you have epilepsy, or I mean, if you have a seizure patient, if you have let me just say it this way: if you have any kind of altered mental status patient, get that blood glucose level. And the hospital is going to want you to do it. Take time on scene, get it, find out where it's at. Is it normal range or not? And then look for an insulin pump. If we are ALS, so we can't do it, but if they're a family, they can do it for them. So this is the fun stuff right here. What goes in must come out, and we got to look at all of it. If there's an issue, Um, what do they do? What do they eat? What do they drink? What went in? What comes out? What does it look like when it comes out? Not a fun project there, but you're going to have these issues. GI bleeds, people that have been sick for days with diarrhea, you're going to want to look at it. You're going to want to give the report to the hospital. Sometimes the hospital's going to ask you to take it with you. I've never done that, but um, sometimes they will. But you want to be able to describe it to the hospital so they can see what potentially is going on. Is it bloody? Is it not bloody? Is it coffee ground looking? If it's coffee ground looking, the bleed is further up in the body, in the digestive tract. So fun stuff. So oral intake. When was the last time they ate or drank anything? What's their pain like? 1 to 10. Um, do they have any gastrointestinal issues? Have they had it before? Have they had blockage? Do they have tumors? Did they have surgery? Just obtain that history. Again, a lot of times with the pain, go back to that OPQRST mnemonic to help with these things. Does the pain begin or get better after eating? Um, did you eat and then the pain happened? Get that OPQRST. Does the patient have a history of the issue? Has he been vomiting? And if so, how frequently and what did it vomit look like? Again, was it coffee grounds or was it bright red? This will change how you have to perceive. Um, Bowel movements. Has the patient had a bowel movement recently? And if so, how frequently? How does this compare to normal? What did the stool look like? Dark or tarry stool may indicate digestive blood. Bright red blood may observe in the stool as toilet tissue. You got to look at the. Sorry, this is not a very fun part of the job, but you got to find out is it dark and terry, coffee grounds, or bright red. Bright red, not good, but not as bad as coffee grounds or dark and terry, tarry. So you want to definitely look at whatever you can look at so you can describe it to the hospital. And then you're going to observe the patient's position. The position of the patient is, on his side, laying flat, feels better when he sits up, what kind of position he's in. Um, you're going to want to palpate for the 4 quadrants of the abdomen. Does it hurt worse when you push in? Does it hurt worse when you let go? Does it, feel better when you push in? Does it feel better when you don't touch it? Assess that abdomen. Do you feel anything? Do you feel distension? Do you feel um, hard? Does it feel distended or does it feel soft? Does it feel rigid? Inspect other parts of the gastrointestinal system. And then also inspect vomitus or fecus if available. Chances are, if they've been vomiting pretty frequently and you don't see it, they're going to vomit pretty soon, so pay attention to it. And inspect other parts of the intestines, and then take a look at the feces. Again, not fun, but it's in your book. I'll be reading through it. I'm kind of breezing through it pretty quick, but just want to, again, get that history, and then look at everything you can look at. Allergic reaction is most relevant for EMS is anaphylaxis, and that's part of the immune system. So history of allergies, if so, what are typical reactions like? A lot of times if someone has allergic to bees, they're going to know what's going on more than you will because they know their bodies. So if they get stung by a bee, they probably will carry an EpiPen if they have their own problems already and they've been prescribed, but a lot of times they'll forget them or not have them. So what are the typical reactions like? Ask the patient. I had one not too long ago where a lady got stung by a bee, forgot her EpiPen. She was still alert, awake, alert, and oriented, and her airway was patent, but she found me. Someone wasn't from this community, but they were here traveling through, and so someone knew me somehow and came looking for me, and she was able to talk to me. And I said, so when did you get stung? Oh, about 10 minutes ago. And I asked her, has this happened to you before? Yes, I have an EpiPen, but I forgot it at home. So my next question was simple, was, well, how much time do we have? What's your typical reactions like? And she says, you got about 5 minutes, and I'm going to start closing up. My airway will start closing up. So got her in the back of the ambulance and checked her vitals. You always do that. Check your vitals for everything because you want to make sure that you're not giving epi inappropriately, or improperly or whatever. So got the vitals. Sure enough, she was definitely, going south. So we gave epi, and sure enough, monitored for a while, and she came out of it. So they know. Symptoms of tightness in chest or throat. A lot of times the airway and the chest will start closing up. They'll get, so imagine this again, perfusion, right? So the body's not taking in the air it needs to because the throat's tightening up. So the heartbeat's going to go tachycardic because the heartbeat's going to try to carry more blood to carry more oxygen. Blood's not the issue, it's the oxygen that's the issue. But yet the body's immune system is overreacting. So tightness. Medications for allergic reaction is um, epinephrine. Perform physical examination. Inspect point of contact with allergen. Inspect patient's skin for hives. Inspect the face, lips, and mouth for swelling, and listen lungs to assure adequate breathing. So again, obviously, if it's a respiratory issue, you're going to want to feel those things. But a lot of times, these guys will have a rash around where they get bee stung or allergic to food, whatever caused that anaphylactic shock. So look for those things, and a lot of times patients will carry their own Benadryl. You got some pretty gnarly pictures in your book of that, the lips and the hives, and um, those things are pretty nasty. And epinephrine and transport really is what we're going to do. Musculoskeletal, so physical examinations is following our elements of musculoskeletal system physical examination. So um, inspect the patient for signs. So medical diseases in this system are rare, as the slide shows, but does happen. So bone's most important aspect to assess. You want to feel, is there anything broken? Um, Basically deformity and swelling is what you're looking for. Um, and then find out, is the patient taking blood thinners? A lot of times if they're taking blood thinners and they have a broken bone, um, you want to take severe action to that. Palpate areas which you suspect injury. Palpate gently if deformities are obvious. Palpation should never cause injury. So if you see an injury and you're going to palpate, do it cautiously, but do enough to feel the deformities. Be alert for crepitus, the feeling of bones ends rubbing together as you palpate. Um, that's going to feel more like it's going to sound like when you listen to it, it'll sound like pop rocks in your mouth, but it feels kind of like bubble wrap. Really, you kind of hear pop, 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 pop. So when you feel it, it kind of feels like that. Um, I felt it one time in a guy's torso, thoracic, where he hit the steering wheel in a car accident. Um, in the head-to-toe assessment, you will palpate all major areas and extremities. This is often done when there's multiple injuries or the patient is unresponsive and unable to tell you where he is injured. So, one, I agree with that. Two, I don't. One, I do a head-to-toe assessment on every trauma. So, even if they tell me where the pain is, I'm still going to feel everything anyway. So, again, that's where you just quickly go from the head down and you palpate everything to find all the injuries. If you find a life threat, you stop, take your life threat, and then keep your assessment going. Inspect for signs and injuries such as deformity and palpate areas with suspect injury. We're going to be alert for crepitus and assess patient head to toe if there are multiple injuries. Boom. Secondary assessment of the medical patient. So this is the part where assessment varies depending on patient's ability to communicate. So responsive, medical patient, focus on chief complaint. Not rocket science, that's pretty much what you're going to do. Patient's going to tell you, hey, I have a lower abdominal pain. So you're going to focus on the chief complaint. Unresponsive medical patient, you focus on physical findings, things that you see. So again, signs are things that you see, symptoms are things patients tell you. So if the patient's responsive, you're going to follow their leading with that, and if they're unresponsive, you're going to follow the physical findings. Take a history of present illness. Again, you get that history, what led up to this. We use sample, OPQRST. Take a past medical history, doesn't line up. Perform physical exam. Um, you know, Whatever the case might be, that with the chief complaint, you do your physical exam. Obtain baseline vitals, and that way you have a trend that you can follow. You got the baseline. Now your next vitals, you'll follow the trends, and administer interventions and transport the patient. Obtain from patient, and then obtain from family or bystanders. So however you got to get that assessment or that history, you get it. Um, if the patient can't talk because they're in anaphylactic shock, as you work on the patient, have the bystander talking to you about what happened. And then again, to keep the open-ended questions going. Chief complaint: why patient activated EMS? And then what is bothering the patient most? So, a lot of times they'll ask, why'd you call us today? That's an open-ended question. They're going to tell us. Don't ask, hey, you need an ambulance? Because they're going to say yes or no. Why'd you call us today? And they're going to tell you what happened or what's going on. And then you just start from there. What is bothering the patient the most? They have more than one thing going. So as you do the present illness's onset, what were you doing when the pain started? And we covered all this, so this is getting repetition a little bit. But what were you doing when the pain started? Provocation, does anything trigger the pain? Quality, describe the pain. Again, open-ended question with that. Don't say, hey, is your abdomen hurt? Describe the pain. So, a lot of times these will help too, because what were you doing when the pain started? Well, I was working in my yard and I started feeling pressure in my chest and being short of breath. Okay. Does anything trigger the pain? Does anything trigger the pain, or does anything trigger the pressure point more or less? Well, when I'm laying down, it gets worse, but I'm lightheaded, so I lay down and it pressure gets worse. But then I sit up, it kind of relieves a little bit, but not much. Okay, so that's kind of the description. So, well, can you describe that pressure for me? You see, and then they're gonna say, well, it kind of feels like there's a vice right around my chest. Okay. So take a history. So region, relief, where is pain? Does it seem to spread or shoot anywhere? So okay, so all right, Bob, does the pressure in your chest, does it move anywhere? Does it go down? Does it move any part of the body? Well, it hurts my back too, my lower back, but it's starting to hurt my right shoulder. Okay, so that gives me direction a little bit. And then severity on a scale of 1 to 10, 1 being the not at all, 10 being the worst pain or pressure you've ever felt in your life. Where's that at? Man, it's about a 9 right now. Okay, so is it gotten worse since we got here? What was it when the pain started? Well, it was a 6 in the yard, but now that we're talking and we've been together, it's gone to a 9, so it's going south. Time. What time did it exactly start? When were you working in the yard? Oh, about noon. Well, now it's 2 o'clock, so I know it's been going on for 2 hours. Past medical. Have you had this pressure before? Have you had these symptoms before? No, maybe maybe about a year ago. Same time of year. Okay. Are you allergic to any medications? Are you allergic to anything out in the environment? Because sometimes we're thinking heart attack, right, with pressure. But if there's allergic reaction going on, we got to know that, and that can happen from cutting the grass. Maybe he has COPD and he's actually lightheaded because he's having difficulty breathing and his heart's going tachycardic because it's trying to compensate. So always get that history. Don't make too many assumptions. Are you on any medications right now for this? You said it started a year ago. Did you do anything for it? Well, I went to the doctor, and their tests were kind of inconclusive when they came to the heart, but they did prescribe some blood thinners and whatever. So okay, did you take that medication today? Have you taken your blood thinners? Well, I haven't taken it in about a week. Okay, pertinent past history. Just go keep backtracking to get much history as you can to be like a cop and find a conclusion. So when was the last time you ate or drank anything, Bob? Well, I started cutting grass at noon, so I had a late breakfast about 11:30, brunch. All right, events leading to the illness, we got that already. So tailoring the physical exam for specific chief complaints is going to be important because you don't want to do the same thing every single time. You want to make it relevant. So important information can be gained by tailoring history to patient's chief complaint. So ask questions pertinent to the chief complaint. So once that guy Bob starts telling me about the pressure in his chest, that's where my target is. You don't want to forget about everything else, but that's my target. Body systems approach, focus, questioning, and examination on particular body systems most likely involved. So when it came to the chest pressure, I'm going cardiovascular, right? So because the pressure sounds like that, but I'm not going to take away the potential of something else, but I'm hitting the cardiovascular system. So now my questions are going to involve that. So just remember that from previous chapter, the body system, musculoskeletal, endocrine, cardiovascular, nervous system, right? All these different parts of the body. When they give you that chief complaint, now you can target one of those body members, systems, and that's where your questions are going. Get on the same level with a child. Do not hover over them when you're doing your assessment. Hey kid, tell me everything you know. I mean, get down on their level. Play with their toys if you have to. Put questions in simple language. You don't want to be, going all medical with them and giving them words they don't understand. Say, hey, hey Brad, I don't know, whatever his name is, Brad, um, what part of your body hurts the most? If you fell down the stairs, or hey Brad, does your chest feel funny when you're trying to breathe? Just I don't know, break it down a level. I'm not a good pediatric guy, but I do what I can. Gather information from the people around them, especially mom and dad. Man, they're gonna know more about that kid than anything. If they're panicking, calm them down as best you can, but let them help you. Be brief with your exam. An exam, you're not like you. It's just treat it like a clinic. When you're there, you're in, you're out. So usually be brief and then examine areas of concern based on chief complaint. As you can see there, lung sounds, you know. Baseline vitals is essential to assessment of medical patient. So, I mean, obviously it is. Your baseline is going to be everything. I've met people that don't do baselines. It's ridiculous. If you're in the ambulance and you're going to see a patient, get that baseline instantly, and then assessment of vitals will be compared to baseline. So everything from that baseline. You get on scene, it's one of the first things you do. Hey Brad, why'd you call us today? No, my chest is hurting. I was cutting the grass and I lost, my chest pressure just, started and I was kind of getting short of breath. So I thought I better get checked out. Okay, Brad, can you sit down for me? When did this start? As he's answering my questions, but when it started, I'm getting him hooked up to the monitor or I'm taking manual. Do not be scared of manual. I'm checking his blood pressure. I'm feeling his pulse. I'm checking his pupils. I'm looking at his skin color. And as he's talking to me, I'm monitoring his breathing. So all that's going on, but my baseline is where everything's going to come from. So remember, a decision for prompt transportation or critical patients or those with specific complaints is part of a treatment plan. So, hey Bob, why'd you call us today? I was cutting grass, my pressure on my chest got started, and I just started feeling pressure on my chest, and I was getting short of breath and lightheaded, and it just hasn't relieved. So I thought I'd better call you. Okay, Brad, I'm checking all my assessment, right, doing all my set of vitals, and once I gauge from that point, from the baseline vitals, like man, he is having a heart attack, and we gotta go now. Boom, load and go. It's part of my assessment. Okay, that's going to be crucial, and that's going to be test, lots of tests. And I'm going to tell you this right now, when it comes to your practicals, you can get everything right almost. You miss that, you're fail. And that is the most crucial is we're going to load and go or we're going to stay for a little bit. So where would you focus your physical examination on a patient complaining of shortness of breath? Obviously, it's not going to be nervous system, right? So you're going to focus on airway, respiratory. Unresponsive medical patient, begin with physical exam and baseline of vitals. Then gather history from bystanders or family members and do rapid assessment of entire body. Also part of the rule of thumb is if there was a witness collapse, not a witness collapse, someone just found someone laying in the field, you do rapid assessment. Anyway, so when they're unresponsive, perform rapid, so similar head to toe physical exam for trauma patients, but assess head, neck, chest, abdomen, pelvis, extremities, and posterior. So I don't know why they say similar to head and toe. That is a head toe. I mean, head, neck, chest, abdomen, pelvis, extremities, and posterior. So get all that done when they're unconscious. Look for the JVD and then also look for devices of diabetic, epileptic, whatever. Something that tells you why they're unconscious or if they have a medical history. Listen to breath sounds and abdomen distension, firmness, or rigidity. So basically it's the same thing, but you're not talking to the patient. You're just rapidly going through everything to see how to treat them. Pelvis, incontinence of urine or feces. A lot of epileptics will lose bodily fluids as well, but that also will tell you that they lost brain. Something going on with the neural system where the brain wasn't communicating to the body. Extremities, pulse, motor function, sensation, oxygen, saturation, medical identification device. So basically you want to make sure the pulse is beating, you want to make sure the motor functions is there, and you want to, cap refills will help with sensation. They can't talk to you, but they get good cap refill, they get good perfusion, oxygen saturation. And then check pupils. Are they pearl? Assess pulse, respiration, skin, pupils, blood pressure. See if they're unconscious, get that baseline, and then take note of any abnormalities. Obtain baseline vitals for ALS personnel. Consider a request for ALS personnel. It depends on geographic options, types of facility, and available. So basically, we kind of covered that a little bit. I mean, bottom line for us is if we're and Kit Carson, and we got that chest pressure. Brad's cutting grass, got chest pressure, got problems. We can do a 12 lead to give to ALS, and it'll say whether there's a heart attack going on. But I'm going to read to the hospital. Say, hey, we're in a route. I would recommend. Well, let's say it's a stroke alert. So again, we're there. So let's say Brad, he had that chest pressure, but while we're talking to him, all of a sudden he's got left-sided droop, weakness, and facial droop. Um, I'm like, whoa, okay, we just went to a stroke alert, and so we radio the hospital. Say, KMH, this is ambulance one, go ahead. I tell them this is what we got going on. So when I radio the hospital and I'm on scene, and they say go ahead, I'm going to say I'm with Brad. He's a 39-year-old male, or well, let's go 59. 59-year-old male was cutting the grass, started feeling pressure in his chest and losing shorter breath. Um, Called us for assistance. His baseline vitals are this, his blood pressure is this, his pulse is this, his pupils are pearl. But as we're talking to him, he also got left-sided facial droop and left-sided weakness. I'm going to call this a stroke alert. Let's get air life moving, and I'll meet him at the hospital. Any questions or concerns for us? Boom, done. ALS is on its way. So, question bystanders. What is the patient's name? What happened? Did you see anything else? Did the patient complain before this happened? Does the patient have any unknown or any known illnesses or problems? Is the patient taking any medication? So basically, you're doing the same exact thing you would do with someone if they're awake. You're just doing it to someone that's not awake, and you're using a bystander to help you. But you want to get that history, because maybe the boyfriend is there. Yeah, she's an epileptic, been having seizures for 5 years. Well, that helps a lot actually, because um, you can ask the bystander, are they normally post-ictal for a while? Because that happens. Sometimes it takes people a day to sleep off a seizure. So all that's going to matter. Use the bystanders. Um, Administer interventions and transport patient. Look for mechanism of injury, signs that suggest a spine injury. So did they fall off a roof and that's why they're unconscious? If needed, immobilize the patient's spine. Yep. So basically, what I say to that is, if it's an unwitnessed, and I think it's in your book later. Correct me if I'm wrong, but I believe it's an unwitnessed. Someone saw someone unconscious. You got your baselines. You got everything. You still treat them like a spinal patient. Because you don't know why they're unconscious. Did they fall off a tree? Did they fall off a bike? There'd be a bike there, but who knows what's going on? So, but if needed, immobilize the patient to a spine board if you questioning, think about that. What other mechanisms might you have to obtain patient history other than speaking to bystanders? Be a cop. Look around the scene. Look through their house. Look through their medicine cabinet. I don't know. All that kind of stuff helps. Boom. Boom. So mid-chapter review. Mid-chapter. This is a big chapter, guys. The secondary assessment of the medical patient takes two forms, depending on whether the patient is or is not responsive. And so I kind of want to say it this way too, though. Your assessment changes. Sure, it's more rapid if they're unconscious, but you do the same steps, but you just use the bystanders to help answer questions. So, secondary assessment of the trauma patient. Injuries can range from slight to severe, in case you didn't know that about trauma. But, fact is, some people can have a broken leg or they got a ruptured spleen. Obviously there are going to be different stuff. To determine how serious an injury is, consider location of injury or injuries on a patient. Patient's mental status. So, everything's going to revolve around mental status, big time. But also, where is the injury? Is it, to the patient? Is it thoracic, torso, chest? Determine how serious an injury is. Patient's airway. Is it patent or not patent? Vital signs. Is the blood pressure low or is it high? Mechanism of injury. Was it a car wreck, fall off a tree, punch to the face, baseball bat to the head, and a patient's age or pre-existing conditions. So with that said, that's pretty darn important right there, because you can have you can have a 20-year-old in a car accident with a broken hip, no big deal. Get them to the hospital, you splint the hip, get them to the hospital, get them x-rayed. Patients in their 60s or late 70s and they're on blood thinners, now that broken hip is a whole different ballgame, because they're potentially got internal bleed going on. So all that's going to matter. Is focus on areas the patient notes are painful or that the mechanism of injury, MOI, indicates. So focus on the area that you might thing. So like if they fell off a roof, with the roofing and they fell off the roof, what part of their body hit the ground? Did anything hit them first before they hit the ground? Did they hit scaffolding first, then the ground? That's all going to determine how you focus your assessment on the where the injuries can be, and also what that MOI looks like. Determine the chief complaint. You know, oh man, they landed on their shoulders, so that means they're also going to have fell on their neck. So the chief complaint to me is going to be the neck and the shoulders to make sure. So that there's not a spinal injury. Conduct a history of present illness to gain information on how injury occurred. Did they slide off the roof? Did they trip on the roof and tumble down the roof and then off the roof? What the patient tells you is the matter. So that's going to be your chief complaint. Nature of force involved: car accident, falling off that roof, falling downstairs, playing baseball, got hit in the head with a bat. Direction and strength of the force. Was it a 10-year-old that swung the bat or a 40-year-old that swung the bat? Was it a 20-foot tree or was it a pine tree? Was it a 17-foot roof or was it a shed? Protective equipment used by the patient. Were they wearing a helmet? Were they wearing a rope? Were they wearing, the seatbelt? Actions taken to prevent or minimize injury. So obviously that's all in the training in your book. That you want to take the proper actions. You don't want to cause any more injuries, so you want to take care of everything you can to minimize the injuries they already got. Areas of pain and injuries resulting from incident. So, anyway, I was just looking through the book to make sure I didn't miss anything, but I think we're pretty good so far. So, areas assessed depend on injuries and the chief complaint. So, when you do your physical exam, so your decision on which areas of the patient, it depends on the part you can see and what the patient tells you for a chief complaint. Mechanism of injury may point to potential injuries, which is obviously true. If they're in a car wreck, right? We saw that in previous chapters. Head to the windshield, sternum of the chest, lower hip, legs to the dash. All that's going to, mechanism of injury will point you in the proper potential spot for injuries. 3 techniques to observe. Techniques is the observation. Your eyeballs looking around, scanning the body. Palpation, touching the head to toe assessment, and auscultation. Listen to the breath sounds, equal chest rise, heart rate, all that kind of stuff. So when you're doing an exam, abnormalities and symmetry. Color, shape, movement. Is there any deformities? And in your book, I'm not sure if we get to it in the slide. Let me check. Yep, we do. Want to look at the color. Are they ash color? Are they cyanotic? Are they pink, warm, and dry? The shape, anything deformed? Their legs pointing in the wrong direction. And then can they move? So abnormalities in shape, you palpate it. So go down. A lot of times you're not going to see with their clothes. They call it trauma naked, and so big thing there is that you want to cut their clothes off so you can see. Not just feel. You want to see. It's part of the assessment. You're not going to see necessarily a broken bone in the femur when the pants are on. So cut them. And if there's abnormal shape, as you feel it, do you feel the deformity? Do you see the deformity? Temperature. Is the body equal in temperature, for example? I mean, if they got a artery being, clipped off by bone, is the leg got the same temperature as the rest of the body, or is it colder? Texture, sensations, and also for decreased or absent breath sounds in the chest. Is it equal? Is it clear? And is it abnormal or absent? DCAP BTLS is a powerful one. Deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, and lacerations and swelling. These are all things you're looking for. And it says it in your reports. When you have a trauma call, they want to know in your report. DCAP BTLS, did you find deformities? Did you find contusions? Did you find abrasions? Did you find punctures? Was the patient burned? So this is kind of a method, just like sample. DCAP BTLS. After the physical exam is conducted on a trauma patient, then assess his baseline vital signs and take it past medical history. Um, so again, after the physical exam, boom, you go through the primary exam is conducted on a trauma patient, assess his baseline, start that vital signs, and take past medical history. So start with your sample. Start with your going back to the medical side. Um, so there you go. Same thing. Signs, symptoms, allergies, medications, pertinent past medical issue, last oral intake, and events leading to the injury. Sorry if I said that too fast, may not have recorded. But anyway, I don't want to be so repetitive. We got a lot of slides to go through today. But the fact is that you do your primary assessment, treat all life threats, find all that DCAP, BTLS, get them splinted, get them do whatever you got to do. Then start your vital signs and go through your sample history. Um, and then a C collar is one of those deals where if you see a mechanism of injury, or they have a history, they fall off the roof, or you see a sign and symptom that indicate, use it. You can clear C-spine. It could be a car wreck, and you can still clear C-spine. You don't have to put a C-collar on there, but the mechanism of injury calls for it, the history calls for it, and you see signs and symptoms that indicate it, use it. But I would rather be cautious and use it than be wrong later, like we said with the step-off fracture. So make sure collar is correct size. Measure it with the from the ears down. You measure with your fingers, like you see in this picture here. Measure the patient's neck with your fingers, then you measure it to the collar, and then you put the collar on. And we're going to practice all that as well. Apply a cervical collar. So assess the patient's neck prior to placing collar. Because one thing you've got to realize is once you put that collar on, it's on. You're not taking it off. So make sure there's no JVD. Trachea is in the proper spot. There's no punctures. There's no DCAP, BTLS in that neck. And then reassure the patient. Neck C collars are usually a sign of bad things. So reassure them it's going to be okay. We're going to put this on just to be safe. Right size. Remove jewelry. Remove hair. You don't want anything getting jammed up in there. Keep the patient's head in line, in an anatomical position, and then slide the collar in place from the front. Never go from the back to the front. Front to back is what you do. There goes a picture again. So, collar alone does not provide adequate inline mobilization. Must be paired with manual stabilization or fixation to a longboard. So, if you believe that there's a C collar issue, there's probably go the whole 9 yards with the vacuum mattress, all that kind of stuff. So trauma patients with serious injury or multi-system trauma, high priority, continue spinal stabilization, and then consider a request for advanced life support ALS personnel. So basically, your scope only goes so far. Now we're into ALS scope sometimes, so be ready for that. So there you go, secondary assessment, patient with significant trauma. So rapid assess each part of the body, head, check for wounds, tenderness, deformities, plus crepitation. So DCAP BTLS. Recurs only a few moments and should be performed at scene. Care provided en route will be based on this assessment. So basically, when you get on that scene and you're starting your assessment and you're doing a rapid head to toe, you're basing the rest of your treatment on that moment. You're making the calls from that spot, so make the right ones. Find those injuries and start treating for those injuries. Performing rapid trauma assessment, palpate cranium, face, ears, eyes, nose, and mouth. Blood or clear fluid are serious findings, especially the clear, it is, especially out the ear. And the neck, it could be, so we start with the head, right? So palpate the cranium, face, ears, eyes, nose. This is test. This is your practicals right here. Head, palpate the cranium, face, ears, nose, mouth, and report all findings. Neck, tenderness, deformities, and jugular vein distension, stoma or tracheostomy, all that. So check the neck and then note your findings. Assessing the chest, as you palpate, just so you see there, palpate down, find any deformities, DCAP, BTLS, and applicate, and then go from there. So when you're in the chest, paradoxal motion, crepitation, and breath sounds are all important. So not only do you palpate, like you see there, palpation, But you also want to listen to those breath sounds and note any um, paradoxical motion, crepitus, and breath sounds are clear or not clear, equal or not equal. Rib cage and chest must be exposed, trauma naked. Um, Abdomen, distension, pulsating mass, gently press down on all four quadrants. Um, and then the pelvis, bleeding, priapism. You want to feel for those things. Do you feeling deformities? DCAP BTLS. Rapid assessment of the extremities, tiredness, deformity, circulation, sensation, and motor functions. DCAP BTLS. Rapid assessment of those things. And the assessment of the abdomen is a good way. I'll do that right there at all four quadrants and note any findings. Rapid assessment of the posterior body and immobilization on a backboard. So before you board them, feel down, roll a patient on its side, and then check out that back all the way down, and then lay him down in a supine position and obtain baseline vital signs and past medical history. Use pulse ox if applicable, but anyway. So you lay them on the board, now they're secure, and note any findings. But make sure that you do this. People don't do this anymore as much as they could. But you want to find any deformities in that back, anything that needs to be noted in that back before you lay them on that board, because they're going to be there till the duration. Communicate with patient. Expose injured areas before examining. So when you do your assessment, and you're cutting clothes off and you're exposing all the wounds so you get eye contact, assume spinal injury and stop or alter assessment process to provide care. So as you're going through the head to toe, okay, you get on boarded, you're an ambulance now, you're doing a secondary assessment, you're doing a third assessment. So you take care of all the life threats, keep going in assessment, and then if you have to change how you're providing care, do it. You know, if there's something else that pops up, like, oh man, their blood pressure's tanking right now, and it wasn't tanking on scene, but now they're tanking. So you got to alter how you're taking care of that patient at that time. These are just good motor function things to check, make sure everything's working. Pulse points. Pediatric note is lesser mechanisms can cause significant damage. Obviously, that's common in a pediatric. You know, takes less effort to hurt a kid. You know, so we got to keep that in mind for our assessment. Explain assessments more thoroughly in this population. And so trauma patient assessment video doesn't work, but you can see that they're going to go through everything here. Detailed physical exam, typically completed en route to the hospital. So now that you got them in the back, you go through a detailed exam, gather additional information, comments, primary and secondary assessment. So basically everything you're doing is assessment, treat, assessment, treat, assessment, treat. And it's always going to change potentially. So, excuse me. You're going to have different things taking place when you find a different injury or whatever the case may be. So you're always going to be changing. But main thing is on scene, you got the primary exam, you do your secondary exam, and then you just keep going. Performed after all critical interventions completed. And then primary assessment, reevaluated again before initiating. For these patients, you will have assessed almost the entire body during the rapid trauma assessment. Now need to assess the entire body more thoroughly to possibly reveal signs or symptoms of injury you may have missed or that have changed since the rapid trauma assessment, which we kind of covered. So everything about this process is assessment, treat, change. Assessment, treat, change. Assessment, treat, change. You're always going to be assessing. You don't ever want to sit down and not do something in the ambulance. So every time you assess, you're going to find potentially something new. You change how you are taking care of the patient. Remember to perform this only after you have performed all critical interventions. If you are treating a severely injured patient and are too busy to complete the detailed exam, it is not a failure. So I want to repeat that because that is important. If you are treating a severely injured patient and are too busy to complete the detailed, it is not a failure. It is your responsibility to give the patient the best care possible, which means you're taking care of that life-threatening issue. So if it's going to take all your focus, it takes all your focus. But you don't want to do an exam, ignore that, and let them die. So remember that. You do your assessment until you find a life-threatening issue, and then you intervene that life-threatening issue until it's no longer an issue. Expose the patient, trauma naked, work around immobilization equipment, and components similar to rapid trauma exam, more detail and focus. Trauma patient who is not seriously injured generally does not need a detailed physical exam. Keep a high index of suspicion, and when in doubt, perform a detailed physical exam. So basically, just it doesn't require it all the time if they're not as seriously injured as a critical patient, but keep your suspicions up in case something goes south. Be aware of the patient's fear and need for emotional support. Bottom line, that's important too, guys. I mean, I've had a patient who got in an accident, was perfectly fine, not one physical problem with them. But their blood pressure and heart rate was through the roof because they're just anxious. I mean, they went through a traumatic deal, even though they weren't hurt. I had them back in the ambulance, and I watched them until their vitals went normal range, and then and gave them supportive care. We didn't even leave the scene. We're just sitting there, giving supportive care, watching their vital signs until it got back in normal range, and the patient was calm enough to make her own decision. It was like, okay, I'm going to go home. Signed a refusal and didn't transport. But that supportive care is important. Mid-chapter review. Just keep going through the chapter, guys. So your reassessment, and we're almost done now, I think, continues on initial steps of assessment. So everything you do builds on each other. So your initial steps, now you're continuing on, identifies changes and trends. So okay, you see changes in their demeanor. Maybe they weren't mentally altered, now they are. Maybe their pulse ox was normal range, maybe it's not now. Maybe they're tachycardic when they were, and who knows? Things change, and as they change, so do you. You must never skip a step, and then always do life-saving interventions as you need to. Changes, identify changes, and some are small, some are big. Trends, watch those trends. Like I said, assessment, vital signs. Watch the trends, make sure they're in normal range, and if they deteriorate, recognize it, intervene with it. If they improve, awesome. You're doing a great job. So communicate with the patient, explain the process, consider patient's feelings such as anxiety or embarrassment. You got them naked, you got them strapped down, they're very exposed, and it can be very embarrassing for them. So be aware of that, give supportive care, and keep them calm by explaining every single thing that you're doing. I'm going to give you an IV now because I see, that I want to replace some of this fluid that you lost through your blood loss. Explain that. Or, hey, I'm going to do another assessment, and explain that. Just watch those things. Repeat the primary assessment, recheck for life-threatening problems, assess mental status, airway, breathing, pulse, skin color, reestablish patient's priorities. So as you do your reassessment, again, reestablish patient priorities. Maybe at first their priority was their oxygen, but they're doing great on that. But now they're bleeding in their lower abdomen. Sorry, I had a kid walk in. But maybe now they're they're bleeding from a leg wound. So their priority has to change. So all of it's going to change. The mental status of an unresponsive child or infant can be checked by shouting, verbal stimulus, or flicking the feet. Just a little trick to learn to check they're responsive. Crying is an expected response from a child with an adequate mental status. Obviously, if you're going to flick a kid, they're going to cry. If they don't cry, there's something definitely going on. Reassess and record vital signs. Keep track of those. Compare results with baseline measurements. Reevaluate oxygen saturation and document findings to record and identify trends. So important stuff there is document the findings. Watch those trends. When you get to the hospital, you want to be able to give them all the trends. Repeat pertinent parts of the history and physical exam. Chief complaint may change, especially with regard to severity. So absolutely, for a while they might have the distraction of, man, my head hurts because I hit the windshield. You got them spinalized, you're on the way to the hospital, but now all of a sudden their hip is hurting. Like, man, things change. Their head no longer hurts as much, but now they're on a backboard, let's say, and now their lower back is hurting. So you got to roll with the punches there. Ask about changes in symptoms. Like, hey, is your pain, you said your pain was at a 9 out of 1 out of 10. Where's it at right now? Well, it's at a 7. Okay, well, it's getting better. Repeat pertinent parts of the history and physical exam. Repeat physical exam to identify changes from baseline. Check all the interventions that you're doing. And I want to say something about that where it says check. Sometimes you need to stop, and I call it timeout. When we have a critical patient and we're in the back, we're working on them, I'll take a point and I'll say, okay, guys, everybody stop and step back for a minute and I take a time out and I look at everything to make sure that we are still doing what is most important. Check all your interventions. Ensure adequacy of oxygen delivery, ensure management of bleeding, ensure adequacy of other interventions. Observing the trends, repeat reassessment steps frequently. Establish and document trends. Like we learned in the legal chapter, documentation, documentation, documentation. You can't over document. Observing patterns that have emerged among vital signs. So if things tank, you're going to have vital signs to prove it and show that you were monitoring it. Trends may indicate new treatment, adjustments to ongoing treatment. Patient's condition as well as length of time with patient will determine how often you reassess. And the more serious patient condition, the more often you will reassess. That's absolutely true. On this slide, it says here every 15 minutes for stable patient, every 5 for unstable. That's absolutely true. Transfer, if you're going from KMH to Denver, this is just for our department. This is not test purposes. Test purposes 15 and 5. If they're not critical, I'm okay with 30-minute vital signs. So every 30 minutes, you're getting vital signs on the way to Denver or the Springs. But when you're here for test purposes, 15 minutes for stable patients, so you should get 3 vital signs, or every 5 for unstable. And if you believe there may have been a change in a patient's condition, repeat and go. Reassessment. Okay, chapter review. So, critical thinking. Diagnosis, label for condition. Based on history, physical exam, vital signs, what do you think is going on? Involves both physical and intellectual activity. So it's strange that they're asking EMTs to do this, but they are nowadays. In the report, they ask you to give a diagnosis. What do you think is going on with the person? COPD, asthma, car wreck, hypovolemic shock. Weird. I'm not a doctor. We're EMTs, but how a clinician reaches a diagnosis is like a cop. Clinicians have a different level of training, experience, time, technology, and other resources. Techniques vary among types of clinicians. So assess the patient, list of conditions or diagnosis, differential diagnosis, or the differential. So further evaluation, reevaluate the differential, and final diagnosis. Quickly rule out and treat immediate life threats, stabilize patient, return to gather additional information, focus on ruling out worst case scenario. Red flags suggest problems are serious. So, basically it's just investigation stuff. You want to rule out the life threats, but then you want to stabilize the patient, but then you want to go back to him and reassess to get more information. Then you want to focus on the ruling out worst case scenarios and any red flags. So maybe responsible for multiple patients. You're going to sometimes have 2 patients in the back of the ambulance and you're hitting it. So it must be very efficient, be available for another call as soon as possible. And then work on uncontrolled environment, limited tools and skill sets, narrow educational focus. So anyway, so follow the same steps as emergency physicians. Most are abbreviated or limited. Consider most serious conditions associated with the patient, rule them out or in or out, and then it creates a diagnosis. So think about it. You can reach a diagnosis, but your work is not done. Why? Anyway, experienced clinicians learn shortcuts. They pattern recognition. They feature narrowing possibilities. So they kind of just narrow everything down to what a couple possibilities, the 50-50 chance kind of deal. Allows efficient diagnosis and prompt treatment. So basically, like when we're on a call, as EMTs, we're not going to diagnose. I don't know why this is part of it, but it is. So just learn it for test. But we're going to be able to know when to give a neb, not to give a neb because of a diagnosis process. Narrow it down. Realize limitations of shortcuts. Understands common biases of the shortcuts. Represent ability, overconfidence, confirmation. Anyway, just read this, I guess. Sorry, I'm not much help on this part. Read this part. I don't understand what they're going through. But for registry, I do know there's going to be a lot of diagnosis. You're going to have to do it. Learn to love the ambiguity, which is change, the constant change and different things, and nothing's ever normal for us as EMS. Understand limitations of technology and people. Realize that no one strategy works for everything, and then form a strong foundation of knowledge. So also I think that it says that they'll realize that no one strategy works for everything, because it doesn't. There's systems in place for us, but everything changes. Organize the data in your head, change the way you think, and learn from others. Reflect on what you have learned. And some of this stuff is good because I sit down with Dr. Miles, I sit down with Dr. P, Dr. Boland, you know, learn from them. And I've learned stuff that helps me in the field because they help me learn how to read the patient, how to come up with possible diagnoses, and how to treat. So keep that going. So the review. Any questions? Please text me, call me. We're gonna go through this in class as well if we haven't already. Um, um, but sorry about the last part there, the diagnosis part. That gets kind of surprised me. But main thing is the reviews. You can read them, but you go through your assessment. You treat any life threats. You go through, finish your assessment, and then you go through another assessment, and you constantly change your method as you need to help the life threats that are in front of you. So text me with any questions, and other chapters will be coming soon. So I appreciate you guys. Thanks.